and I'm the Director of Policy and Practice for Domestic Violence and Substance Use with the National Center on Domestic Violence, Trauma, and Mental Health. This webinar today will present an overview and highlights of the technical expert meeting on substance use coercion as a barrier to safety, recovery, and economic stability for survivors of intimate partner violence. Today's presenters are Shondell Dawson, Director, Division of Family Violence Prevention Services, Family and Youth Services Bureau from the Administration on Children, Youth, and Families, and the Administration for Children and Families, U.S. Department of Health and Human Services, as well as Kenya Fairley, Supervisory Program Specialist from the Division of Family Violence Prevention Services, Family and Youth Services Bureau from the Administration on Children, Youth, and Families, and Administration for Children and Families, Laura Erickson, Social Science Analyst from the Office of the Assistant Secretary for Planning and Evaluation with the U.S. Department of Health and Human Services, as well as Carol Warshaw, the Director of the National Center on Domestic Violence, Trauma, and Mental Health, and Eleanor Lyon, our Senior Research Advisor with the National Center on Domestic Violence, Trauma, and Mental Health, as well as myself and an individual from our Lived Experiences panel. Before we get started, I'd like to go over some technical details of the WebEx software that we'll be using for today's webinar. Many of these details are explained on the Using this Webinar System tab in the center of your screen. You can switch to the screen from the slides by clicking the down arrow next to Using this Webinar. Please be aware that your screen might look a little different depending on whether you're using a Mac or a PC. On the right-hand side of the screen, there are multiple boxes. Third from the bottom is the chat feature. You may have to click on the chat cloud icon at the bottom center of your screen to open your chat box. This feature will allow you to provide feedback and share resources with your colleagues, as well as get in contact with the trainers or myself if you have questions regarding the training content. You may also contact Carla Alegria, also with the center, if you have questions troubleshooting the WebEx software. To do this, click the down-facing arrow and select the person you would like to contact. You'll see a lot of options. But for this session, you'll want to select all participants if you would like to respond to a question from any of our speakers or to contact center staff anytime during the session. You should click on Carla Alegria to privately contact her if you are in need of troubleshooting the WebEx software. So let's go ahead and test this chat feature. Will everyone please go to the chat box, click on all participants, type in where you're calling from, and then press enter. Perfect. Thank you all so much. While folks can get a lot out of the chat feature, there are times when it moves really quickly and can feel distracting. If this is true for you, feel free to minimize the chat box by clicking the arrow next to where it says chat. You can always open it again with the same arrow if you choose. We will be providing live captioning during this webinar. Below the chat box, there is a media viewer box. This contains the captions. If you don't want to see the captions, click on the down-facing arrow next to the word media viewer, the same way you might if you want to hide the chat box. We have planned time for discussion as well as Q&A towards the end of this webinar. We hope this could be an interactive discussion. At the very end of the webinar, you'll be taken to a brief survey. Please take a moment to let us know what was useful and what could have been better. If you get disconnected at any point, return to the email you received with the original webinar link and re-enter the training. Sometimes the sound cuts out due to internet connection, so feel free to call back in if that becomes a problem. If you're experiencing technical difficulties and are unable to contact Carla, you may call WebEx Tech Support to resolve any issues. That phone number, which will also be posted in the chat box, is 1-866-229-3239. Again, thank you for joining us today. I'll now turn it over to Laura Erickson. Next slide.
Hi, everyone. This is Laura. Thanks so much, Gabriella. I'm really excited to be here today, and on behalf of the HHS Office of the Assistant Secretary for Planning and Evaluation, I just want to welcome everyone and thank you all for joining today. It's really exciting to have the chance to follow up on the October 24th and 25th Substance Use Coercion Technical Expert Meeting that ASPE, FIPSA, and the Center hosted together. To follow up for those who missed it, or as a refresher for any of those of you who did attend, we're really excited to have further discussions about how to continue to address substance use coercion. It's really exciting to be part of this work and to be here today. And I'll just turn it over to Kenya.
Hi, this is Kenya. I hope everyone can hear me. Please indicate so in the chat. Hello, can you all hear me? Am I unmuted? I believe you all can hear me. Okay, thank you. Now I'm seeing the responses that everyone can hear me. And we can go to the next slide. I want to echo a lot of what Laura just shared about this exciting work that we're doing here around substance use coercion. It has been a really great opportunity to work in partnership not only with ASPE, but also with the National Center on Domestic Violence, Trauma, and Mental Health. And so we wanted to share some just thoughts and overviews about why we are all gathered here on this call, and also why we gathered together at the in-person meeting a few weeks ago. We know that people experiencing domestic violence are at greater risk for substance use, and oftentimes that can be because they are using substances to cope with the abuse that they have experienced and may be suffering from very real and physical pain. And we also know that they may be forced into using substances or introduced into using substances by an intimate partner. And we also know that this potential use of substances also creates greater opportunities and vulnerability for being assaulted, violated, and trafficked. And so in our research, which you're going to hear about in a few moments, we really were able to help give greater credence to what a lot of practitioners and service providers have been hearing for decades, and being able to really identify language to help providers talk about what they're seeing and hearing around substance use coercion. So we're excited to have you all join us here on the call today. We want to continue working together to bridge the gaps between research, policy, and practice. And also, we really invite you all to work with us on identifying strategies to mitigate and prevent the risk for survivors. So I just want to thank everyone that's on the call today. And I also want to thank our partners at the National Center on Domestic Violence, Trauma, and Mental Health, as well as I want to thank our person who will be speaking and sharing her story as someone with lived experience related to a lot of the issues that you will hear about. So thank you, and I'm going to pass it over to my director here in the Family Violence Prevention and Services Program, Shondell Dawson. And so Shondell's going to make introductory remarks, and then as you all are hearing about the information from the research and the key informants, we want you to think about some of these questions that are here on the screen in front of you. So we want to be able to help identify some quick wins that you all might be able to incorporate into your work soon. We also want help with identifying some of the future research questions and things that we still need to know. We want you to consider ideas for inter and intra-agency collaboration, and just really think about how substance use coercion shows up for the programs and the people that you're working with through your programs. And then, of course, there will be some opportunity towards the end of the session to talk about longer-term steps and strategies. So please be thinking about some of the questions that are here on the screen in front of you, and then we'll share these again later to open up the discussion when we get to the Q&A portion. So now I'm going to pass it over to Shondell, and she's going to make some introductory remarks.
Good afternoon, everyone. I'm Shondell Dawson, the Director for the Family Violence Prevention and Services Program, and I'm so thrilled to be able to follow up our important conversation we had in October and share that with you all today, because the FIPSA program for the last 35 years has been working with our colleagues in the Department of Health and Human Services and all across federal government and in private communities to address domestic violence as a public health issue and stand in partnership with state agencies and local programs and sovereign nations and tribes to meet the needs of domestic violence survivors and their children. We know that substance use treatment and behavioral health services and domestic violence safety planning and supportive housing are all critical foundations of safety for millions of people who are served by domestic violence programs and social service agencies all across this country. All of you who have gathered here with us today represent this multidisciplinary think tank that we need to help us usher in more comprehensive change that domestic violence survivors and their children and advocates have been sounding the alarm on for quite some time around the significant impact of coercive control, substance use, and trauma has on their lives day to day. We don't want anyone to have to make a choice between treatment and safety in their families. And we're excited to be partnering with ASBE and the National Center on Domestic Violence, Trauma, and Mental Health to help others really know where they can turn when they're facing addiction and substance use and coercive control and homelessness and violence, and doing all that we can to think about how we can expand the existing service model to better meet the needs of families every day. I want to thank our partners in ASBE as well as the National Center on Domestic Violence, Trauma, and Mental Health. I also want to thank the National Center on Domestic Violence, Trauma, and Mental Health. The Family Violence Prevention and Services Act funds a network of training and technical assistance resource centers that focus on this intersection of domestic violence and health and social services and criminal justice systems and child welfare systems. And today we will be sharing the expertise of Dr. Carol Warshaw and her team at the National Center on Domestic Violence and Trauma and Mental Health to be able to talk about coercive control, what they're learning around substance use, what that means for domestic violence survivors, and how they have been working with both clinical and non-clinical staff to support domestic violence survivors and getting connections to services all across the country. I'm grateful for the expertise that will be shared today, and I'm looking forward to hearing your ideas and your strategies on what else we could be doing more together. We are deeply committed to fostering stronger partnerships between domestic violence programs, state administrators, tribes, and state mental health directors, as well as those that are doing work with regards to substance use treatment, housing, and human services. We are committed to sharing our national array of training and technical assistance resources, sharing research and evaluation, and doing what we can to support any development in policies and procedures and resources that will help improve access and services for the millions of people who need our support across the country. So I want to thank you for joining us today. I want to thank you for your commitment to this work and for standing in partnership with us. And now I'd like to pass the floor to our colleagues from the National Center on Domestic Violence, Trauma, and Mental Health. Carol?
Thanks, Shondell. Excuse me, I'm going to be using throat lozenges and tea, so if you hear little noises in the background, that's what it is. And of course, we've been really thrilled to partner with our colleagues from ASBE and the Family Violence Prevention Services Program on this initiative to address substance use coercion and its tremendous impact on the lives of survivors and their families. And we're really glad that you could join us today to think together about how to better address this and substance use coercion and its far-reaching effects, including as part of federal efforts to address the opioid epidemic. So the first part of the webinar, I'm going to provide an overview of the current state of knowledge about substance use coercion and a little bit about integrated services for intimate partner violence and substance use, along with a kind of framework for thinking about all of these issues together and all of the ways they impact people, both individuals, services and programs, and the systems that survivors interact with on a regular basis that many of us have some influence over. So some of what we're talking about today will be challenging to hear, but our hope is to stimulate all of our thinking and creativity and to generate strategies for policy research and practice. As Kenya said, both things we could think about in the short run and things that we'd really like to see happen, changes we'd like to see happen over time. So here's a kind of quick overview, and I'm going to just touch on this briefly because, Kenya, I think you actually covered this, that it's this sort of constellation. This is kind of where we were starting from, because we know that intimate partner violence has significant mental health, and substance use related effects, and that people who access substance use disorder treatment and mental health treatment as well experience very high rates of IPV and other lifetime trauma. At the same time, people who abuse their partners actively use their partner's mental health and substance use against their partners as a tactic of control. And then, in turn, intimate partner violence impacts people's ability to access and engage in treatment, and that's why it's so important to have integrated approaches to these issues. So just to unpack this a little bit, we know, as I mentioned, there are very high rates of intimate partner violence among people who access substance use disorder treatment services. And as you can see, the 47 to 90% data is for lifetime, and 31 to 7% are people who've reported domestic violence or intimate partner violence in the past year, which is, we kind of use as a proxy for ongoing current intimate partner violence. And there's one study by Louisa Gilbert and her group at Columbia that 90% of women who are accessing a methadone treatment clinic had experienced intimate partner violence. Louisa, who is one of our research presenters, also provided some data in her talk about the past year intimate partner victimization rates among non-representative samples of women who use drugs, so not just in substance use disorder treatment. Between 23 and 50% had experienced intimate partner violence in the past year, which is 3 to 5 times higher than rates among national surveys of women. So just to have some context, and again, also very high rates of substance use among people seeking DV services. Let's see. We also know research has consistently demonstrated that there are high rates of a range of health and mental health conditions associated with intimate partner violence and other lifetime trauma. And one way to think about this is that a number of mental health conditions like depression, PTSD, anxiety, panic attacks, that may lead someone to self-medicate with substances. There's also medical conditions like chronic pain and insomnia that may also lead people not only to self-medicate, but to be prescribed higher rate opioids and other psychotropic medications. And there's the risk of suicidality that may be related to intimate partner violence, but may also be tied in with opioid-related overdose deaths that often isn't tracked as suicide or as related to coercion or substance use. We also know among people who are LGBTQ individuals and trans individuals, there are much higher rates of depression and substance use as well. And abuse is often targeted towards people's gender identity, mixed in with the layers of substance use and substance use coercion. So less well recognized historically has been the ways that people who abuse their partners engage in coercive tactics targeted towards a person's mental health or use of substances as part of a broader pattern of abuse and control. For example, as Kenya, as you said, while self-medication is common, a survivor may also be coerced into using by an abusive partner. And part of what we've been hearing from the field and knew about was a constellation of behaviors that were designed to undermine a partner's sanity and sobriety. We had a companion study with the National DV Hotline of over 2,000 survivors who said that 73% of whom said their partners had deliberately done things to make them feel like they were losing their mind or going crazy in quotes. They also, abusive partners try to control their partner's ability to engage in treatment, to sabotage their recovery efforts, to discredit them with potential sources of protection and support, and jeopardize custody based on the substance use and mental health coercion, and then exploit their partner's substance use for personal or financial gain. And we'll talk more about that, all of these things in more depth. So also, as Kenya said, that survivors and advocates have been talking about these types of coercive tactics for many years. Patty Bland, who worked for us for many years and previously at the Alaska Network on Domestic and Sexual Abuse, was one of the kind of people who just started our thinking about this. They did amazing work of really listening to survivors and hearing about their experiences. And we also, as part of our planning for this, for the technical expert meeting, we conducted a literature review. Heather Phillips, from our research director, was the lead on that. And we found that while there were no quantitative studies of substance use coercion, there were a lot of qualitative descriptions that appeared in the research literature over the years since the 90s. But given that, we ended up doing the first large quantitative study of substance use coercion in partnership with the National Domestic Violence Hotline. And the study, we actually did it in 2012 and published our report in 2014. And as you can see, there were over 3,000 callers that were participated in the study. The hotline historically has done what they call focus studies, where if someone is not in crisis and is willing to participate in a brief survey at the end of the call, often people participate because they want to help other people who may be experiencing similar things to them. So of over 3,000 callers who were not identified as using substances or in substance use disorder treatment, 26% said that they had used substances to reduce the pain of intimate partner violence, but 27% said they'd been pressured or forced to use or use more than they wanted. And even more compelling was of the 15% of callers who said they tried to get help for substance use, over 60% said that their partner tried to prevent them or discourage them from getting that help. Interesting, 37.5% said their partners or ex-partners had threatened to report their alcohol or other drug use to someone in authority to keep them from getting something they needed or wanted, often a protection order. A primary tactic was to use this in custody hearings, whether it was in a divorce custody hearing or with Child Protective Services. And then almost a quarter of the callers said that had been afraid to call the police because their partner told them that either they would not be taken seriously or they would be arrested. And I'll talk to you a little bit about how this kind of thing played out. So when we looked at the coerced use, we also, hotline advocates who conducted the survey collected qualitative data as well. And these are some of the things that people said, that there was a continuum of being pressured to use by an intimate partner and being unable to refuse, being manipulated into using or threatened into using, with threats around custody, threats around violence, threats around abandonment, being literally drugged by a partner, and then being subjected to drug-induced debilitation, where they were drugged and then incapacitated and unable to engage in things that were important to them in their lives. We also heard survivors talking about how all the ways that an abusive partner would interfere with their treatment or recovery. So there was one layer was preventing a partner from actually participating in treatment, from attending meetings or treatment, accusing them of infidelity with their substance use counselor or someone in the group, being not providing transportation or child care. And then they would, once someone was in treatment, they would literally harass them out of treatment, like a constant texting or phone calling, sometimes where the survivor would feel like they had to leave, or where the program would exit them and say they're not serious about treatment. Also controlling medications. This came up in both surveys, where they might prevent someone from taking medication, steal their medication, call them an addict for taking medication, or force them to take an overdose of medication. The sabotaging recovery came up in a lot of ways as well, including keeping substances in the home after treatment, having drugs around or needles around, being forced to watch a partner use, and escalating the violence if the survivor really was trying to cut down. So I just want you, as I'm talking, to think about how this would play out in the kinds of programs and that you fund or the services that you're involved with. The other thing around threats to report or discredit, survivors would talk about their partners like reporting their substance use to Child Protective Services, forcing them to use, then videotaping and using the videotape and bringing that to court, forcing them to use or forcing them into withdrawal so they couldn't actually participate in things that were required of them, and then or planting drugs and then calling their probation or parole officer, and making false allegations. And the survivors also talked about substance use-related sexual coercion, which also played out in a lot of ways, pressuring a survivor to use because it made things better, or forcing them to use, or literally drugging them and then sexually assaulting them. And I'll talk about some other forms of sexual coercion when we talk about opioids specifically. And then blaming the abuse on the partner's substance use. So using that as a way to denigrate them, blame them, say the abuse is their fault and they're not worth anything. So, as you may be thinking already, this is really a very disturbing and kind of insidious pattern where survivors of intimate partner violence may use substances to deal with all the traumatic effects of the abuse, and then their partners actively coerce them into using them. They sabotage their treatment, and then they use these issues as a way to control them. In fact, of the 37.5% who said their partners use their substance use issues to report them to authorities or try to exert other forms of control, 90% of those were people whose partners had forced them to use or had prevented them from accessing treatment. So one of the other things that happens, and this is the other piece of the picture that we really need to think about, and our key informants really highlighted, that the combination of stigma associated with substance use really compounds these risks. We've had lots of conversations with judges who are very DV savvy, who do family court hearings, DV court, and so when they're presented with someone who is an abusive partner who looks like they're doing well, and the person they've been victimizing for years who doesn't, they have to make custody decisions. And part of what we've been saying is if a party is bringing this up, you should think about this as a red flag. So there's the stigma, there's the system responses that are often punitive in the face of substance use, and then the lack of access to really comprehensive services that could mitigate these effects with an understanding of intimate partner violence and substance use coercion. So what are the implications for the opioid epidemic? So thinking about this, there are very specific things related to the opioid epidemic, including introducing a partner to opioids and then controlling their supply, which means that imparts a tremendous amount of control, because when someone's dependent on an abusive partner to supply the substances that are necessary to prevent withdrawal, then that leaves someone dependent on an abusive partner. And it also gives them a tremendous amount of power and control. Forcing a partner to use unsafely, we've heard many stories of women who are forced to use with dirty needles or dirty cotton, developing a lot of the medical complications of injection drug use when this is not recognized in healthcare settings, or being coerced to use substances that then induce psychotic episodes and being psychiatrically hospitalized and not having that any understanding of that be part of their treatment picture. The other piece is that leveraging the fear or threat of withdrawal to coerce partners into engaging in illegal acts, including dealing drugs, stealing, theft, and illegal sex work and trafficking. So substance use coercion is also a major route into trafficking, whether it's by an individual abusive partner for their own personal control or financial gain, or by a commercial sex trafficker. So thinking about that as is really critical as we're thinking about both prevention and intervention efforts in addressing the opioid epidemic. We already talked about sabotaging treatment, but there's some very specific things related to the opioid epidemic, including if someone's attending regular appointments for MAT, like methadone treatment or other types of substance use intensive outpatient programs where you have to keep regular appointments or you'll get exited from treatment, it's much easier to stalk someone. So thinking about those kinds of things in the context of our policies and practices around opioid treatment are really critical. And then again, using opioid history as a threat tactic of control. So when you're using substances that are illegal and you've been involved with the criminal justice system, that induces a tremendous amount of fear and leverage that an abusive partner has over someone that they've been victimizing. So again, when we want to think about women in the opioid epidemic, and I know that time is short, so I'm going to really try to just touch on some of the key highlights here. There was a really important conference and then subsequent paper that the Office on Women's Health produced around women and the opioid epidemic. And there are a number of features that are unique to women's experience of opioid use, including the higher rates of interpersonal violence and some of the traumatic effects of it, plus painful medical conditions that lead women to be more likely to be prescribed opioids for chronic pain and for emotional pain, given higher doses and to use for longer time, that women are more likely than men to use medications in ways that they weren't prescribed, more likely to self-medicate to manage distressing feelings than men are. Some of the data, and this is interesting because the And this data does look at initiation into substance use. Often it's by a romantic partner, but nobody is looking at whether people are coerced into using. And that's something that we think is really important to start to include in some of the national surveys that are looking at substance use in general and opioid use in particular. And that women are physiologically at greater risk for becoming addicted in a shorter period of time, face additional barriers to accessing care related to child care and stigma, as well as IPV. And we know that opioid use is a major risk factor for pregnancy-related death and neonatal abstinence syndrome. Another thing to think about physiologically, when we think about the neurobiology of relapse and relapse triggers, we know that relapse can be triggered by exposure to addictive and rewarding drugs, condition cues from the environment, and exposure to stressful experiences that activate a number of neural pathways. And so you think about this in the context of substance use coercion, those pathways can be activated deliberately, whether they're aware of the neurobiology or not, by abusive partners. So again, I think what we're trying to convey is that almost every layer in which we think about substance use and opioid use, there's a layer of potential substance use coercion that needs to be factored in. Again, when we look at neonatal opioid withdrawal syndrome, which is a big public policy issue as well, knowing that medication-assisted treatment is the treatment of choice, and keeping mothers with their children to support attachment and children's development is best for women's recovery and best for children's recovery from neonatal opioid withdrawal syndrome. So, but think about this in the context of substance use coercion, where an abusive partner can deliberately coerce a partner into using, so they're going to test positive, they're going to have child protective services involved, and thinking about that, another layer in this context as well. So when we're thinking about, one of the things that we're hoping to do is also think about, when we think about the drivers of the opioid epidemic, there's a lot of attention to the role of the pharmaceutical industry in promoting opioid use for financial gain, but people don't think about the role of gender-based violence and the role of abusive partners and sex traffickers in coercing women to use substances, or coercing partners, not just women, to use substances, and what role that is playing in our thinking about efforts at prevention as well. So we're thinking about women being at greater risk for developing opioid use disorder for a number of reasons, including physiological reasons, trauma-related reasons, overprescribing and coerced use, compromised access to treatment because there's just not a lot of trauma-informed, gender-responsive, comprehensive two-generation treatment around, but also because abusive partners prevent them from accessing treatment. And also thinking about the increasing risk for being involved in systems, partly because of stigma associated with substance use, partly because of policies, and partly because of abusive partners leveraging those systems against their partners. So again, thinking about all of these issues with a layer of considering substance use coercion. So some of the additional implications in preparation for the meeting, we did two things. We did a lit review, and we did a number of key informant conversations. I think there were 19 conversations with 26 people, and all of the interviews, no one experienced more than 9 of the same set of no more than 9 people had the same set of questions. But these were some of the things that we were looking at, is how commonly do these issues come up, and people said all the time. What types of substance use coercion and were people seeing, and what was their impact on survivors' lives? And I've talked about some of that, and I'll touch on a few more dimensions that came out in the interviews. How does this impact service engagement and outcomes, and what kind of recommendations do people have? There were researchers, people with lived experience, DV providers, substance use disorder treatment providers, one person who worked in the human sex trafficking space, policy people. So there were a lot of different people who contributed. And so these are some of the things I'm just going to touch on briefly. Barriers to leaving an abusive relationship related to substance use coercion, barriers to economic self-sufficiency, which I know is a major priority right now in HHS, barriers related to abusive partners leveraging systems against survivors, and I've touched on some of that, and barriers to accessing substance use disorder treatment and DV services. So one of the things when leaving an abusive relationship, I think some of what I've said already kind of highlights what people's experiences have been. So one is the risk of withdrawal when a partner controls your access to drugs. So that keeps people in abusive relationships when they otherwise might want to be able to leave. A partner controlling their access to services and support, and to keeping them isolated from other people who may be supportive of them. So the things that would help them be able to engage in recovery efforts are being sabotaged. The fear of loss of custody is huge, and that's always a threat. Like, if you try to leave, I'm going to involve Child Protective Services. You'll never see your kids again. And the fear of legal issues. So that's the system leveraging. The lack of options that people have due to a criminal record. So if someone plants drugs, or someone's out on parole, they plant drugs and call their parole officer, or we think about who is literally left holding the bag when the police come. So there are lots of ways that, or someone, an abusive partner plea bargains, and the person who they're victimizing gets a longer sentence. So there are lots of ways that this plays out. And then the psychological undermining that's also debilitating related to substance use. Economic barriers were huge. If you think about it, all the things that abusive partners directly try to control, so you don't have access to resources, you're prevented from going to work on a regular basis or complying with demands of the court to maintain your kids. Housing instability, so that ways that you would be dependent on an abusive partner, ways that being forced to use substances prevents you from doing the things you need to be able to attain economic self-sufficiency. And then once you've been involved in the legal system, that you may no longer be eligible for public benefits like SNAP or TANF, or maybe public housing. So it's thinking about all those layers and how that impacts economic self-sufficiency. So some of the implications for the systems that we all are kind of involved in and work with and have some influence over. So thinking about housing, employment, banking, credit, public benefits, and education systems, thinking about strategies that would help us address the impact of substance use coercion on the ability to access resources that are necessary for economic stability. So maybe asking about substance use coercion, factoring that in, developing strategies and supports to help survivors address that, making sure that people aren't left out of services when this is what's going on and what they're, so it's thinking together about what kind of programming and policy could address those issues. Same with the legal system, strategies to address incarceration for coerced illegal activities, how substance use coercion might impact probation and parole conditions and violations, thinking about the role of incarceration on future economic stability, and the impact of substance use coercion on the ability to call the police for help. So for any of you who work in spaces like Department of Justice, where you're providing training and TA to judges, law enforcement, prosecutors, and attorneys, to be thinking about how this may be layered in and to provide that as part of the training and technical assistance. Same with people who are working in the space around Child Protective Services and family courts, to think about the role of substance use coercion in child custody decisions and ways to support survivors as parents. I think Family First legislation is something that has a lot of promise in this arena, and thinking about two-generation approaches also, since we know that research consistently shows that supporting the attachment to the non-abusive caregiver is really what's most helpful for kids' resilience and development. So when we think about some of the barriers that survivors talked about, DV programs, sobriety requirements have been an issue historically, but currently the issues are really around lack of adequate training and resources, some of which we provide in terms of training, but the access to resources is a huge barrier for DV programs and survivors. For substance use disorder treatment programs, when people don't understand IPV and substance use coercion, there are a lot of barriers that come up. Some have to do with the way services are structured and the requirements for, certain types of attendance, regular attendance, and not being able to factor in the barriers that may keep someone from being able to attend regularly that are sabotaged by a partner. Often having both partners in the same services and co-ed services that can be really make it really challenging for people, or even co-ed services may be challenging because of experiences of trauma and abuse. So those are critical issues, as well as the need for really comprehensive, gender responsive and trauma-informed services. Residential services are often challenging. Not being able to bring your children is problematic, and then also the challenges of group living. When we think about in the health, mental health, public health, and substance use disorder treatment spaces, thinking about the role of substance use coercion in prevention and treatment and relapse and recovery, overdose prevention. Thinking when someone comes in for some of the medical complications of substance use or psychiatric complications, to be thinking about intimate partner violence and substance use coercion. We hear lots of stories of people having multiple episodes of bacterial endocarditis, and then surgeons not wanting to operate another time without thinking about what else may be going on in someone's lives. And then thinking about in the domestic violence service system, really having access to comprehensive both resources in the community and in-house resources. Informants also highlighted a need for a continuum of inclusive, collaborative, and fully integrated services. Gabriella will be talking about this more later, so I'm just going to touch on some of the research aspects of this. So what did we find? And basically, there's some research on integrated services, but not a lot. There were 2 large-scale studies that showed that of over 23,000 substance use disorder treatment programs that provide some kind of IPV services, but they didn't indicate anything about what kind and whether they were for people who were being victimized or for perpetrators. There was another study of 204 self-identified integrated intimate partner violence substance use disorder programs, and they mainly focused on advocacy, service coordination, and group counseling. And what they found was the DV programs were more likely to have external partnerships, and the substance use disorder treatment programs were more likely to have some on-site services. When we looked at outcome studies, there were only a handful. The SAMHSA Women Violence and Co-occurring Disorder Studies showed that integrated comprehensive trauma-informed treatment showed some reduction in substance use. The IPV component was less well developed, and so we don't know as much about that. There was a study of 3 integrated service programs in Illinois, a pilot a number of years ago, and it showed that there was some increased self-efficacy and decreased substance use, but 20% of the survivors expressed that they felt more vulnerable around the intimate partner violence, maybe because they were experiencing escalating threats. And Louisa Gilbert's relapse prevention and relationship safety program showed reductions in IPV and in substance use generally, but not with heroin, not with opioids, and they thought maybe that had to do with chronic pain. But they do suggest that integrated services are beneficial. There are also a number of evidence-based treatments for addressing trauma, women's experiences of violence and substance use, or IPV and substance use, and that are more broad. Some of them have adapted specifically for survivors of intimate partner violence, and there are a handful that are specifically that address intimate partner violence and substance use, but none of them address substance use coercion. So that's partly why we've developed a toolkit on mental health and substance use coercion for both primary care and behavioral health settings, that really provides guidance to clinicians on how to bring up these issues in conversations with patients, how to kind of brainstorm to explore how this may be impacting their lives, and to develop some responses and strategies and brainstorming to address this as part of ongoing treatment that could be layered into any type of treatment modality. So where do we go from here? Some of the recommendations from key informants were probably obvious to all of you as we've been talking about this, and some of the things that I've already touched on. One is improving partnerships at the federal, state, and local level to provide better support to survivors experiencing substance use coercion, increasing access to a full range of treatment services, education and training across systems, supporting research, and supporting economic self-sufficiency for survivors. People also mentioned a couple of other things, federally funded pilots of integrated intimate partner violence and substance use services to really look at what is helpful with a full evaluation component, expanding the reach and flexibility of existing funding streams to provide more cross-sector work and collaborative integrated approaches, and making sure that services, there's a wide variety of service options that are culturally and linguistically responsive, relevant, and helpful to survivors from a range of communities and backgrounds. So some final thoughts from our key informants who shared a very rich array of experiences. First of all, they underscored how common substance use coercion is. They provided lots of examples of how this plays out in survivors' lives, and they emphasized, and this is really important, the importance of addressing system-level issues that really make it harder for survivors who are dealing with substance use coercion, that really serve as barriers to getting help. And so that the systems that abusive partners are able to leverage that we're involved with, we really need to be cognizant of that and to really think through how we can prevent that from happening. And the last thing I really want to highlight was the importance of centering the voices of survivors who've experienced substance use coercion in every aspect of the work we do going forward. So now I'm going to ask you to take a moment and think about some of the questions that Kenya asked you to be thinking about as we're talking about this, about how this shows up in your work. What are some of the things that you can think of that come under your purview that we could start to think about doing? And so just be thinking about that. And now I'm going to turn this over to Gabriela.
Thanks so much, Carol. So now to hear from one of our panelists from our Lived Experiences panel. So the first thing that we're going to ask is, what helped you to escape substance use coercion and be able to establish safety, recovery, and economic stability?
Hi, I'm Jeanette. I have 27 years clean and sober. I'm really grateful for the opportunity to share today. I'll share a bit about myself, kind of keep it in context, and then what helped me on my recovery journey. My dad was homeless due to his alcoholism. He died on a sidewalk between two bars, and he was 44 years old. His death certificate says as the cause of death, cirrhosis of the liver and hypothermia. I was sexually abused throughout my childhood. My mom met the man who would become my stepdad. He was so good to us, her 3 children, and he swept her off her feet. It wasn't long before he was violent. He severely abused my mom and us kids in every way. They had 4 children together. I was the oldest of 7. I began medicating my pain at 8 years old. By age 12, it was daily alcohol and cigarettes. I have no doubt that drugs and alcohol saved my life. When I used speed every day by age 15, I could stay awake all night and keep my brothers and sisters safe. At age 15, my boyfriend was 30. He supplied all the drugs I needed. At 18, my boyfriend was 38. At 19, I was raped by a 52-year-old man that paroled to my boyfriend's house. Without drugs to medicate the pain, I would have killed myself after the rape. The violence and addiction progressed in my life, and I had one abuser after another, each one scarier than the one before. My last abuser was my drug connection, and his substance abuse coercion kept me in the relationship on and off for 7 years. At the lowest point of my addiction, I called the Narcotics Anonymous hotline and began attending 12-step meetings. At NA, I met my sponsor, who had worked at a domestic violence agency. She informed me of resources such as Haven Women's Center for safety planning, advocacy, and case management. I also enrolled in substance abuse services for outpatient drug treatment. Support groups for trauma and addiction was where I found my first connection to others, women who had experienced many of the things that I had. Up until that time, I had always felt alone. When I saw how others were healing physically, emotionally, mentally, and spiritually from trauma and shame, it gave me hope that maybe I could have a different life. With that sliver of hope, I was finally able to leave my abuser for the last time when I had 6 months clean and sober. My daughter was 2 years old. I was homeless my first 3 years in recovery. I struggled with depression and anxiety. I was referred for a mental health evaluation and counseling. Learning about post-traumatic stress disorder and symptom management helped me a great deal. I applied for cash aid and food stamps. Since I was already enrolled in school when I applied for ASDC, I was granted a self-initiated program to continue my education. I utilized the Welfare Homeless Program to obtain my first apartment. Children's Crisis Center provided child care. Many things have helped me: financial aid, scholarships, tutoring, state vocational rehab, assisted with clothing vouchers and fixed the brakes on my car, parenting classes, the recovery community, my church, music, and my faith. The people who demonstrated empathy, believed in me, and had a deep understanding of addiction and trauma made all the difference in my life. I got a job at Haven. I must say that employment and insurance benefits are crucial to success. I learned how to have fun, clean, and sober. I'm still learning about self-care. I've had many mentors throughout my journey, people who've come alongside me with experience, strength, and hope, and I'm forever grateful. I also want you to know that my daughter just turned 30. She has 2 master's degrees, owns her own home, and has never experienced domestic violence in her relationship.
Wow. Oh, that's so beautiful to hear. Thank you for sharing that with us. And then what were some of the barriers you encountered as you were pursuing safety and recovery? What got in the way or was harmful?
I would say the top 3, poverty, homelessness, and then for sure the stigma of addiction. Also, systems that don't hold the abuser accountable for the crimes they commit, and instead of assisting and protecting the victim is blamed, especially in child welfare where the victim is accused of child endangerment and failure to protect. Another thing is couples counseling is really dangerous when there's a history of violence, but it's often done in churches by untrained clergy or in mental health systems by therapists who don't recognize the controlling tactics an abuser is using. Court-ordered co-parenting sessions where the abuser and the victim are in the same class. Family court's at the top of the list of what was harmful to me. I didn't always get separate mediation when I requested it, and I had a restraining order. My danger was escalated by court orders for visitation, having to transport my daughter to the abuser, and denying supervised visitation. Court was a huge barrier because of continuances. My abuser wouldn't comply with court orders, and instead of holding him accountable, the judge would continue the case. I would have to miss class, treatment, or work, find child care, deal with the anxiety of seeing my abuser, escalating my danger over and over again. It took years to get any child support and to finally get a divorce. Abusers are able to harass and control the victim by manipulating and using every system: law enforcement, child protective services, TANF, welfare fraud, Section 8, family and criminal court, immigration, the list goes on and on. I had difficulty navigating services that were compartmentalized and were not trauma responsive. There were constant contradictions. For example, in drug treatment, we spent weeks on assertiveness and setting boundaries. I was encouraged to set boundaries with my abuser. We even role-played scenarios. I tried to explain how that escalated my danger, and the facilitator said, "You're allowing him to treat you that way." Coercive and controlling tactics used in treatment settings were harmful. For example, in order to move on to the next phase of treatment, it was a requirement that we read an autobiography out loud to a large group of our peers. Many were abusers court-ordered to treatment. Due to the sexual abuse I experienced as a child, I didn't feel comfortable sharing my autobiography at group level. I asked to read it privately to my counselor. I was told that in recovery we must be honest, open-minded, and willing, and also that secrets keep us sick. I have many examples of being forced to comply with requirements of various programs in order to receive services. Barriers such as child care, transportation, lack of insurance, and lack of other basic needs were also huge things that got in the way.
Thank you. And then as you think about, people who are continuing to experience substance use coercion today, what's still needed in order to support survivors who are currently seeking recovery and safety and economic stability?
I would say change TANF and welfare to work programs, extending the time a person can be on aid when there's mental health, substance abuse, or domestic violence issues. When the time clock stops due to a welfare to work exemption, the supportive services such as bus passes, child care, and treatment must continue. Change core hours to empower people who want to get an education. Working minimum wage jobs won't meet the basic needs for a family, especially a single parent. Currently, people on TANF that are in school opt out of welfare to work, discontinuing the adult portion of cash aid in order to pursue their education and continue recovery. Improve services by cross-training staff and provide training on trauma-responsive care. Training can't be a one-time thing. It must be ongoing and repeated. Section 8 housing is often the difference between achieving success or being homeless. Our county accepts Section 8 housing applications every 5 years, and people are waiting up to 10 years to get a Section 8 certificate. Access to mental health services, access to substance abuse treatment, mandatory training for domestic violence, substance abuse disorders, and mental health for judges and mediators, especially those in domestic violence court, family and drug court. More training for law enforcement and having the right officers in specialized units, especially for domestic violence and sexual assault. Mandatory training for attorneys, prosecutors, and defense attorneys to understand how memory and trauma affects people in testifying. We must have collaborative, holistic service provision by providers who are cross-trained, including physicians and faith-based organizations. Early interventions in schools, training teachers to recognize behaviors associated with trauma, teaching ways to create a safe, trauma-responsive classroom, and stop suspending and expelling children who are difficult and acting out. Teachers, physicians, nurses, clinicians, counselors, advocates, etc., need to be aware of ACEs, the adverse childhood experiences, and the effects that childhood trauma has on adulthood for people with high ACE scores. On-site child care as much as possible. Looking at our own agency's policies and making changes where needed. For example, if a victim goes to a domestic violence shelter, many shelters have limits on the number of children or the age of a boy, or exiting a victim who's under the influence of drugs and alcohol, rather than understanding and using that as, to refer or a warm handoff to treatment providers, drug treatment providers. And then more funding for, I would say, all kinds of integrated collaborative approaches.
Thank you so much, Jeanette. Thank you so much for sharing your experiences with us and for helping to really, help us understand what's still needed and how many times the very things that are meant to help may have unintended harms as well. So thank you.
Thank you.
So now an overview of the panel on integrated and collaborative program services. Next slide. So here were the different model programs that were featured on the services panel, and I will provide a summary of some of the different services as well as some of the different experiences that each of these individuals shared with us. So Angie from Beacon House told us about how Beacon House provides domestic violence safe shelter and community advocacy services and takes a fully inclusive approach to serving survivors who are using substances while also supporting recovery for those who are interested, ready, or already engaged in recovery. So taking a really comprehensive and survivor-defined and inclusive approach within their shelter and advocacy. Their services are led by the women in their program, and they found that by incorporating cross-training and an awareness of substance use coercion throughout their programming, staff are better equipped to meet the needs of survivors experiencing substance use coercion while also cultivating an environment of peer support, which Angie shared is one of the most powerful and healing aspects of their program. They also have been able to create strong collaborative partnerships with local substance use disorder treatment providers, as well as successfully built collaborative relationships with their child welfare system to support parental safety planning around substance use, while also supporting survivors in maintaining and regaining custody of their children. And then Irene Lindsay Brantley joined us from Women in Transition, where she is the program director. And Women in Transition evolved to address the intersection of domestic violence and substance use in response to the self-identified needs of the women in their program since 1985. Their community-based advocacy and counseling program that support survivors in healing from the impact of the ongoing effects of domestic violence and substance use coercion on relapse and recovery, including having to navigate prolonged custody proceedings involving an abusive ex-partner. This program also provides domestic violence and substance use integrated recovery groups at local substance use disorder treatment programs, as well as prevention programming in their community. Irene shared that they use an empowerment framework that supports survivors by meeting them where they are and can link to formal substance use disorder treatment programs when needed and desired by the survivor. And then Allison Malinowski Sunday, the Executive Director of Lafayette House, joined us as well and shared with us that Lafayette House began as a domestic violence safe shelter and evolved to include a comprehensive, gender-responsive, trauma-informed, two-generation substance use disorder treatment program, including medication-assisted treatment, in addition to community domestic violence advocacy and legal advocacy services, and that this evolved in response to the input of survivors accessing their services. Allison shared that all the services they offer are available to survivors regardless of which program they enter through, so they really modeled a no wrong door approach. Survivors drive the programming by selecting from the menu of available services for themselves and their children, and the program takes an approach of supporting emotional and physical safety while also fostering an environment of peer support. Allison shared some early successes with their state's Family First initiative to support survivors as parents who are dealing with substance use and domestic violence so that they can remain with their children as they access wraparound two-generation services to support family recovery and family safety. And then Gwendolyn Packard from the National Indigenous Women's Resource Center highlighted the importance of incorporating Indigenous thinking and traditional practices in addressing these intersecting issues, naming harm reduction as a way of life. Next slide. So as represented by the event panelists, collaborative and integrated services can come in many forms. And so some of the main ways that we see these show up, and of course there are many more ways that this can be done, but we see that programs can be informed of the dynamics of domestic violence, substance use, and substance use coercion through strategies such as cross-training, interdisciplinary teams, and strong referral partnerships. And I think that Beacon House is a really great example of what it looks like to have really DV services that are informed by substance use coercion and substance use. We can also see that programs have active collaborations across domestic violence and substance use fields. And this is some of the strategies here that we see are staff from DV organizations, anti-DV advocacy, and substance use disorder treatment, co-facilitating groups at both organizations, having active linkages that has, warm handoffs and really having those intentional collaborative services. And this can also include co-location of services. Of course, always keeping in mind the different safety needs and safety measures that need to be put in place. And then we also see integrated services. And so having, such as Lafayette House, having both formal substance use disorder treatment and domestic violence advocacy, the array of services from both parts of the field fully provided with fully trained staff, and that these are provided in an integrated fashion that still centers safety and survivor choice within the model, so that really modeling that no wrong door approach, and that the program is really built around the survivor's self-defined needs. And so looking at how available collaborative and integrated services are, our key informant interviews of providers and people with lived experience found that collaborative and integrated services are somewhat hard to find, and our environmental scan of substance use providers who provide DV services found that there was as Carol mentioned, no differentiation between providing DV services to those who use violence, power, and control against their intimate partners versus DV services to people experiencing abuse. So it's really hard to tell how available services are for survivors of substance use coercion actually attempting to access the substance use disorder treatment. What we do know from our interviews and environmental scan is that integrated and collaborative services are the exception to the norm, despite how common experiences of domestic violence, substance use, and substance use coercion have been found in both the research and in the key informant interviews. Absolutely, all signs point to more collaborative and integrated services are needed. And so, next slide. Now I'm going to hand it over to my colleague, Eleanor, who's going to talk to us about the research and policy implications.
Thanks, Gabriella. Next slide, please. The panel included the four people you see displayed there. Myself from the National Center on Domestic Violence, Trauma, and Mental Health, two prominent researchers, and Dr. Gandrotra from SAMHSA. Next slide. So I began by talking about some of the work that the National Center has been doing very recently and plans for our ongoing work. Next slide. The first is a needs assessment survey that we conducted with domestic violence programs. You can see very recently states, territories, and tribal nations with over 500 programs responding, so a very good representation, and it focused on needs and capacity related to substance use and mental health. I talked only about the substance use component. Next slide. And what we found was that programs were reporting changes, increased demand for substance use disorder treatment services. 3/4 of them did. If we had been talking about a longer time frame, then certainly that would have been a higher number. Also reported changes in the kinds of substances, with the biggest increase being in opioids. Next slide. When we asked them about their preparation to support survivors, really only 1 in 5 said that they were very prepared to meet needs of survivors who have substance use related problems. And then when we focused on those who were parenting and struggling with substance use, even less reported that they were very prepared. Next slide, please. We asked them to identify the top 3 resources that they would find useful to support work with survivors. Each of them could identify 3, as I said, so these figures do not add to 100%. And clearly, ready access to treatment services, whether taking the form of referrals or more on-site services or co-located specialists, were the number 1 resource that programs wanted, which also clearly was identified by key informants and all our sources. Next slide, please. We also conducted a survey of states' substance use disorder treatment systems, which we refer to as the state survey. This was in partnership with the National Association of State Alcohol and Drug Abuse Directors, also extraordinarily recent, and we had representatives from 26 states and territories, so nearly half. Next slide, please. There, yes. So when we asked about the partnerships that they had, only half had any kind of partnership at all. And less than 1 in 5 reported that that partnership was solid. And most were with state agencies that oversee funding, either at the federal or state level. Next slide. We asked about barriers to collaboration, and in both of these services, I must add that this is a very just highlights So there's a lot more information that we will be able to report from both of these surveys. Major barriers, limited time, limited funding, so funding that helps to prioritize and provide for time. That's a major cluster as the top barrier. And I want to point to the one on the bottom here, that these state representatives said that they had limited information on the prevalence of domestic violence among people needing substance use treatment. So the clear need for more information about the intersection and then certainly about coercion. Next slide, please. This asked about what in the different states that were represented, what they're doing or not doing. And the top of the list was that their opioid plan does not address domestic violence related needs. So there are a very interesting array of potential for changes in policy or support for policies that states have tried. Some have reported they have strategies to increase the treatment workforce knowledge of domestic violence, and they do offer some training. But there is still some siloing and other issues that could be addressed at the state level. Next slide. So we asked for suggestions. The first three for service delivery, you'll notice overlap with what DV programs reported that they felt like they would need and would be helpful to them. So there's a lot of work that needs to be done to decrease barriers, enhance training, provide resources to facilitate access to treatment, and also in funding that is focused on screening and treatment, having requirements for screening and treatment. Next slide, please. Other work that the National Center has been working on is the development of a substance use related coercion scale. It's nearly complete. It will take various forms, and there'll be versions for practice, and we're planning to pilot. Next slide, please. The toolkit on coercion, Carol mentioned that in her introductory comments. We've tested this in Colorado with 5 programs, and where they used it, they found it helpful. So we anticipate further testing. Emily Rothman provided a presentation based on her research. She's been doing research in Vermont because it does have a higher overdose death rate, and she's focusing on issues in particular related to Child Protective Services. There's a high rate of children in Vermont who are younger than 5 and are there because of opioid involvement. So she described her current study, which involves 3 phases. She described the needs assessment component, which was largely done through qualitative interviews with mothers who'd experienced both domestic violence and substance use, and some serious system-level issues needing resources and training and collaboration. Next slide, please. Louisa Gilbert has done extensive research, as well as Emily, and so she presented an overview of some of the strong connections between substance use and domestic violence in the literature, reported on a study that she completed of 352 women in community corrections, and if they also reported intimate partner violence, they were more likely to experience overdoses. She reported that only 6% of women who use drugs who need domestic violence services actually get them, and reported some of the research on WINGS, which is a 1 to 2 sessions screening, brief intervention, referral to treatment program that addresses both domestic violence and substance use. And she has tested it extensively, and it's been shown to be effective in community corrections as well as in other contexts for treatment. Next slide, please. Dr. Gandotra from SAMHSA provided an overview of the extensive research activities and resources that SAMHSA is engaged in or provides, and he identified some of the research needed, which you see here from their perspective: social determinants of health, prevention outreach, cultural differences, differences in tactics depending on the substance. There were many others that he identified. Next slide. And we had additional research recommendations both in the panel and in subsequent discussion the next day, one of which is to enhance our data relative to prevalence of the intersection between substance use and domestic violence through existing state and federal surveys, some examples of which you see here, and including questions about substance use initiation and coerced use, sabotage or interference, and the impact on sexual violence, as well as just looking at the types of substances that are used and their impact. Final slide is we need more nuanced qualitative research as well as quantitative research on the pathways, types of coercion and impacts, both on adults and on children. There was a real concern among the participants as well as panelists on the impact on children, as well as evaluation and testing. All important to contextualize the data in the context of social, racial, cultural, gender, and economic difficulties and disparities. And I'll turn it over to Kenya.
So this is Gabriella. Now with the time we have left, we'd like to really hear from everyone who's had the opportunity to join us today and think about what are some ways that this might, what are the ways that this might impact some of the work that you do, and how do you see this coming up from your role within your office? And I'll invite Kenya to join me in helping to kind of facilitate this portion of the discussion.
Hello, can you hear me now?
We can hear you.
Yes, okay, perfect, thank you. I was double checking, I apologize for that. So yes, thank you for that introduction, Gabriella, and also thank you to Dr. Wershaw and to Eleanor and Gabriella, as well as to Jeanette for sharing her personal story about what her experience has been. Thank you so much for having the courage to do that and for opening yourself up to us. We really appreciate that insight and perspective. And so I think we only have a few more minutes left, but we wanted to see if there was any feedback, and you all can certainly share that in the public chat. I think it's a small enough group that we can manage any of the questions that come in, but we also just want to capture your reflections from what you've heard on the webinar today. Does this information resonate with what you've seen in your grant programs, in any of the state or local services that are being provided through your grant programs, and does this resonate with what you've been hearing from people who may have experienced domestic violence, trauma, and or had substance use disorders? So the participants that are on the line, if you can post some comments related to that in the public chat, we would greatly appreciate it. And then we also, as you all are gathering your thoughts and sharing your information, we also want to think about there's a great deal of research that happened throughout the course of this project over the past couple of years, but we also are wondering if you are thinking of any potential research gaps that we could look into. I know that during the in-person meeting, there were a lot of great ideas that came up, particularly around looking at research related to pregnant and parenting survivors, also wanting to think about the impact across communities that people may be experiencing, and I think our panelist who spoke about her own experience talked a lot about the issues related to poverty, to housing and homelessness, as well as the inability or the lack of some service systems to hold abusive partners accountable. So just share with us in the public chat some of your reflections on that, and make sure that you have selected near the public chat where it says to, just be sure that you have selected all attendees so that we can all see what your comments are. So I'm just pausing so that there's an opportunity for people to respond. Also, if you have any questions about what you've heard, please feel free to indicate that in the public chat as well. One of the things that I know it come up for me, and I believe came up for some of our other federal colleagues at the meeting, and I'm just looking back at my notes from the in-person meeting and thinking about, for example, some of the quick wins that we can consider. So one thing was around ensuring that we talk about substance use coercion as part of the definition and the dynamics of domestic violence, sexual violence, human trafficking, and just a really broad look at intimate partner violence. So that may be something that you all can begin to very quickly incorporate into the work that you're doing when you're talking about domestic violence and trauma. We also had talked about being able to incorporate some of this information into PowerPoint decks for briefings, for trainings, and things of that nature. And the National Center on Domestic Violence, Trauma, and Mental Health, they have developed a short set of slides that you all will make sure you have access to in the follow-up from this webinar, but really that look at the intersection of these issues. And so there may be 1 or 2 slides, and I think we also have up to 6 slides that you can pull from and just insert those into the information that you're already using. So being able to introduce the issue of substance use coercion as well as the intersection very quickly and easily into your talking points, your briefings, or trainings. We were also thinking about being able to help promote the toolkit, but then also the toolkit that I think you're going to hear about in a couple of minutes when we look at resources. There's a toolkit that the National Center has made available on this issue as well. And so those are a couple of ways that we thought about being able to have some quick wins around incorporating this into our work. And a couple of other things that we heard, thinking about having a brown bag lunch with some of your colleagues and sharing this information with them and some of what you've heard and what you've learned. Also considering, as you're developing funding opportunity announcements, if there are ways to incorporate some of this language into either research or services so that there can be opportunities to really encourage partnership and collaboration at the state and local level for service providers. So those are a few just quick win things that we want you all to be thinking about over the next several weeks and months as you're hearing this information and kind of digesting a lot of what we've talked about. So I'm just checking to make sure I didn't miss anything in the public chat. Okay. So I'm not seeing anything right now, so I think I'm going to go ahead and pass it back over to my colleagues at the National Center to talk about some of the resources that are available and to begin to close us out from the webinar. Thank you.
This is Gabriella with the National Center, and we have a variety of different resources available on our. Oh, go ahead.
Go on. I was on mute, but go. You do it.
No, that's fine. Go ahead.
So anyway, we don't have a resource slide in this deck, but because at the convening we handed out a handout with lots of resources, so we'll make sure that you have that available. But as Gabriella was saying, we have a lot of resources on our website. We have a page that highlights the information memorandum that was jointly issued between SAMHSA and ACF on the intersection of mental health, substance use, and DV, and which has some of the infographics that can go into slides and the information memorandum itself and a partner guide. We also have a slide deck that we can share separately that isn't on the website yet. And we also have a web page that's new. We're going to be updating our whole website, but it has a lot of information for mental health and substance use disorder treatment providers that kind of adds a lot of the information that we have, that substance use coercion is one piece of it, but also in a broader context. We have the coercion toolkit and the original survey report on our website. We also have a guide of recommendations for suicide prevention lifelines that we did with a contract with SAMHSA a number of years ago and the National Suicide Prevention Lifeline about how to think about when a caller is experiencing DV, where there's some information about coercion in that as well. And then a lot of other resources on these intersecting issues on our products page. Plus, we have a whole webinar series on the intersection of IPV, trauma, and opioids, with some of them that we've produced ourselves and some that are by guest speakers that also address some of these issues. Gabriella, can you think of other things that I missed? We'll also have, there are also the reports that were in the handouts for the meeting that, including the surveys that Eleanor talked about, we had summaries of them, and we'll be developing full reports on those that will be out in the next couple of months. And we provide lots of training and technical assistance on all of these issues.
Yeah, I think that's everything for now. So if we're ready to conclude?
Kenya, Laura, were you going to make Shondell make some concluding remarks?
This is Kenya. I would like, go ahead, Laura. I was just going to say I would like to offer Laura the opportunity to make concluding remarks, given that I've had an opportunity to share some of my thoughts and reflections. Go ahead, Laura.
I was just going to say thanks so much to everyone for joining, and I would say encourage everyone, as you have additional thoughts on ways to follow up, please be in touch with any of us who are on the webinar today. We would love to think about how to move this work forward, and thank you all for joining us.
So if we can go to the next slide. And with that, we have concluded our webinar. Thank you everyone for joining us today. And thank you to Carla for making the webinar run smoothly. Last but not least, thank you all for spending your time with us. Within the next week, we will send you all a follow-up email with a link to the recording of today's webinar, in addition to the slides and handouts referenced, all of which will be available on our website. Well, I'm not sure that a recording will be available on the website, but the handouts referenced are. You'll also receive a certificate of attendance for your time today. At the end of this webinar, you will be taken to a very brief evaluation. If you could please take a moment to let us know what was useful and what could have been better, it would be greatly appreciated. Thanks again, and we hope that you have a wonderful afternoon.